Good afternoon all. We're just going to give it another 1 or 2 minutes just to let everybody, some of the late attendees, join us this afternoon. Right, I think we'll get started. So good afternoon all. Welcome to our 4th clinical learning event as part of the Modern Ward Rounds Collaborative. My name's Daniel Smith. I'm a respiratory trainee in Nottingham and I'm one of the clinical associates for the Emergency Care Improvement Support Team. And it's my great pleasure and privilege to be one of the leads for the Modern Ward Rounds Collaborative for ECIST, working with our fantastic partners, the Royal College of Physicians, Royal College of Nursing and the Patient Care Network. Today we've got a fantastic presentation, or 2 fantastic presentations, and then a Q&A session about high-risk times, out of hours and handover, things which are not core focuses of the Modern Ward Round documents, but are important parts of obviously every one of ours working day. As you can probably tell, I'm slightly losing my voice, as I've spent the last 3 days on call in a respirator mask, and probably proof, if you ever needed it, that I like the sound of my own voice too much. I'm losing it due to overuse. So hopefully my voice will manage for the rest of the day, but if not, we've got fantastic colleagues who can jump in like Crystal to help chair. The first thing that we want to do as part of our session is just to get everybody in the audience thinking a little bit. So we use a lot in this collaborative Mentimeters. It's a fantastic way of kind of hearing from the crowd and the audience. So if everybody on their phone, on their work computer could go to menti.com or use your camera of your smartphone to go onto that QR code there and utilize that to go to menti.com, and we've got 4 or 5 questions to go through to hopefully stimulate some conversation for our Q&A with our expert group later, but also just to influence our speakers about things they can cover in their presentations. So firstly, let's go to menti.com, and Crystal will go on to the first question. So first question, do you currently have a successful functioning hospital at night team? And we'll give this a few minutes to load up. And obviously there's very many different models of a hospital at night team. That might be very junior doctor led, it might be working with ACPs or hospital at night practitioners and ANPs. But do you have currently a successful functioning hospital at night team? And so interestingly, about 50-50 so far, and we've got 16 people on the call, so.
Got it.
Excellent. Okay. Thank you, Crystal. So just about the majority saying yes, we have a functional hospital at night team then. And do you currently have a successful functioning patient at risk or similar teams? This is a team, and we'll hear from one of our expert speakers today about their team, but this is a team that would go and assess patients who are at risk of deterioration, either by escalation from the nursing staff or due to their early warning score. Who could be a multidisciplinary team going to assess a patient and try and resuscitate them and prevent further deterioration. And it looks here that although it's 50-50 really in a functional hospital at night team, a lot of teams have a similar successful functioning team. And on to the third question, please, Crystal. And I suppose this is a question for those who are on the call who've worked in either leadership or in a hospital that has not got a successful hospital at night team. Have you tried to set up a hospital at night team or patient at risk team in the past? We'll give that a few more seconds. So yes, so the majority have either in the process of or have in the past set up hospitals at night and BAR teams in the past. Excellent. And then the final question we'll move on to is, what were the main challenges you faced when you tried to set up these hospital at night teams and these patient at risk teams? In my organisation, we call it the acute response team. So looking for that clinical lead and recognition within the trust. Yeah, it's amazing how much out of hours is not recognised by some kind of trust senior leadership, even though on a weekday it's kind of 2/3 of the day, isn't it? Lack of support, clinical engagement, convincing the organisation to fund, and clear processes. And staffing, I think, is going to be one of our core items today, isn't it, for our presentations and our Q&A session at the end. Excellent. Okay, so as I said earlier, we've got 2 fantastic speakers today, both talking about different initiatives to help the out of hours hospital. Our first key speaker is probably a face you'll recognise well if you come to many of these Modern Ward Round collaborative events. It's Dr. Andrew Rochford. Andrew is one of our clinical directors for the Emergency Care Improvement Support Team. He's also a consultant gastroenterologist at the Royal Free. And kind of fun fact for the day is that Andrew has never ordered any food over a kind of a Just Eat or Deliveroo app. And that just shows that currently you can't be doing any hospital at night work because it's the core way of sustaining the hospital at night workforce at the moment. So over to Andrew, and we're going to have a really interesting talk, and then we'll move on to our second key speaker. Over to you, Andrew.
Thank you very much, Dan. I have to say I had to act down as a medical registrar a couple of times last year, and someone did order a doner kebab pizza, which arrived at A&E at 3 o'clock in the morning, which was by their app, which was a total experience to me. The night shift, however, was not. So anyway,
Breakfast of champions, though.
Indeed. So thank you for the opportunity to talk, and I'm really excited because we're joined by a friend and colleague, Sarah. And Sarah and I have known each other for many years, and our paths have crossed both clinically, personally and professionally, and her presentation to come is fantastic. The presentation I'm about to give is just summarises some of the work that we've done historically, or I've been involved with historically, around hospital at night, and I think it's relevant to the Modern Ward Round Collaborative, both in terms of the clinical context, but also in terms of the QI approach and the challenges which I'll highlight. And then it'll segue nicely onto Sarah's talk, which highlights how she's overcome some of the challenges that we all put together in the Mentimeter a few minutes ago. So next slide, please, Crystal. So the Hospital at Night program was actually set up as a concept in 2003, 2004. Some of you may remember it, but also I put this in because many of you may not. And it was started by the Modernisation Agency, and you can see the philosophy around it, which is in the slide there, but it was around multi-professional working out of hours and trying to work based on clinical competencies rather than grades, hierarchies, or in silos. And before they set up the program, they actually did large data collection exercise, and they captured information about 20,000 clinical episodes from 11 trusts for all episodes of out of hours care. Next slide, please. And what they found in this sort of preliminary pilot was, unsurprisingly, the clinical activity fell out of hours progressively, but there was a significant amount of work still to be done, at least up until the early hours of the morning. And if you looked at the pie chart on the right-hand side, you'll see that the vast majority of the calls out of hours, so that's from midnight in this scheme, were for those patients who were physiologically unwell. Actually, life or limb-threatening calls to the medical team or the night team was relatively small, but tended to be somewhat unpredictable. Now, I haven't overlaid this information on this graph, but I'd like you also to think while I'm talking about your admission profile from the emergency department in your hospital. So you'll see the clinical activity on the left-hand side, that graph dips, but we also know that the admission timings tends to climb during that time as well. And that's relevant around handover and some of the processes that Sarah's going to talk about as well, and as well as being relevant to the hospital at night. Next slide, please. Thank you, Crystal. So, I mean, when I was putting the presentation together, it just made me smile a little bit because this was 18 years ago, and the principles from hospital at night are still principles that are a challenge to every organisation up and down the country 24/7 at the moment. So the idea was to try and ease the demand of work at night, and by doing that you'd extend the working day, you'd reduce out of hours operating, you'd maximise primary care availability, and you would optimise things like treat and transfer. Now, in certain conditions, you could argue that's been achieved. So hyperacute stroke, heart attack centres, major trauma, all of those kind of things. And it is increasingly common to find clinical networks for transfer of patients, but it's not the norm. We have, I think, successfully reduced out of hours operating to and moved successfully into the NC pod list, but in terms of drawing work into an extended day and maximising primary care, that remains a huge issue. And the principle about the design of the hospital at night team was this multi-professional team, and the schema there is a bit difficult to interpret, I'm afraid. But again, to reiterate, it's about clinical competency rather than professional demarcation and grade. But it did require enhanced practice and clinical training for all clinical staff, and that was one of the key challenges that continues to be faced. And I think Sarah will touch on that in her presentation. Next slide, please. So, having been involved in some of the original work in 2003 and 2004, indeed back at Barnet and Chase Farm, which is now part of the Royal Free Group where I am now. I was back then as a junior doctor. And then when I went and worked as a more senior junior doctor, if that makes sense, as a registrar in Newham, on both occasions when we looked at the hospital at night practices, what we found, and I suspect for many of you on the call, if you looked at your clinical hospital at night practices, you'd find that it's pretty patchy. The teamwork is variable, often dependent on individuals or individual teams. The work depends on what happens per day of the week, and I'll come on to some data to look at that in more detail. The handover practices are not robust, so they're not reliable, reproducible. There's again, non-robust detection of deterioration, and Sarah will come on to that in her presentation. And as we found at Newham, and I'll present the data on this, what we found was despite looking at the hospital at night practices in fairly regularly, every 2 or 3 years, what we found was it was really difficult to sustain improvement. And we're going to talk about some of those challenges on the call and hopefully explore that further in the question and answer session. Next slide, please. So what did we do? We undertook a refresh of hospital at night. This is back in 2009, 2010. And the reason for highlighting this is because it's very typical of the QI approach we'd recommend for the Modern Ward-Round Collaborative. We actually put a bid together with the trust and the education team so that we could fund medical students for the evening shifts during the week and all day at the weekend for 7 days. We had to do it in the university holidays, so we couldn't detract from their clinical time, and it was voluntary. But we managed to get a medical student shadow for every clinician that was on site out of hours for 7 days. And we actually took the original pro forma, which is available online and is shown there on the right hand side. Now, I'm sure you could make that electronic, but at the time we just printed paper and people collected it, and then it allowed us to codify the data and capture the data. And then we surveyed the medical student observers, and I'll come on to that because it's one of the key things. And we've talked before on the collaborative around the importance of qualitative as well as quantitative feedback. And I hope that this presentation will demonstrate the value of that. Next slide, please. And what you get with the quantifiable data through this through using those sheets is you get results. And I've just put one aspect up here. There's a whole raft of them, but I didn't want to flood you with graphs. But what we found was that you can get information on the mean number of calls per shift per grade, and you can see that on the left hand side, so I should say the blue bars are the weekday nights, the orange bar is weekend days. This is Saturday and Sunday 8 AM to 8 PM, and the grey bars are Saturday and Sunday 8 PM to 8 AM, so the weekend nights. And so that's why you've got the medical FY1 and medical FY2 and the surgical FY1 have only got one bar because they weren't doing nights at the time. But you can see that the medical registrar is busy at the weekends during the day than they are at night, but the medical SHO, that's the third from the left, is pretty much the busiest person most of the time. Next slide, please. And so what this project enabled us to do was actually evidence the clinical behaviour and activity that was happening on site at night. And what I found in my previous experience, I welcome comments on this, and particularly as I'm now seen as a more senior consultant, is that we tend to make decisions based on anecdote, and that's why, joking aside, it's quite good to do the odd night shift because it is different seeing it rather than the anecdote you get told when you come in the next day. So the project showed that we were busiest for medicine on a Friday night, but actually Saturday night was the busiest for surgery. And that was important because it broke down some of those barriers that people thought, oh, the surgeons are always in the mess and the medics are always busy. And actually Saturday was particularly busy for surgery when we looked at it. We also identified that Wednesday night was the quietest night in the hospital for everyone. I use the term quiet loosely. We found that the busiest period was between 9 and 11 o'clock in the evening, and that was important because that was the busiest time also in ED. And so that meant that patients on the ward were often waiting while the limited resources were redirected towards the emergency department. We were able to look at some instance, I haven't presented it, but we were able to demonstrate potential harm for patients who were deteriorating on the wards who weren't attended to till later. We see that most referrals from ED happen between 9 and 2 in the morning. That also coincides with the evening drug round and the number of bleeps to the junior doctors at the time. But the junior doctors were prioritising the ED over wards unless there was a medical emergency call. We found at weekends during the day, we handed over sick patients for review, and there was, if you like, mini ward rounds from the junior doctors at the weekends, but those were often interrupted by multiple bleeps. And what we found was that the sickest patients who were identified as needing review were reviewed latest in the day, so late afternoon, early evening. And we found many incidents of routine work being left behind, particularly drug charts being reboarded, and several of which led to clinical harm for patients. Next slide, please. So that was the quantitative data, and that was really helpful in terms of our clinical engagement and creating a case for change. What I wanted to highlight was the qualitative data that we picked up from surveying the medical students. So you can see here that actually they all had most of them, I say not all, but the vast majority have a very positive experience. It was highlighting how surprised they were, how hard they worked out of hours. But also, if you look at the bottom line here, the person I shadowed was supported by other staff from different teams in the hospital. And so 61% of the students agreed with that, which suggests that there is actually an element of team working over and above what is formalised. Next slide, please. I really like this slide, and I really enjoyed doing this because one of the key things for us was we were able to persuade the medical school of the value of medical students working night shifts. And it's purely based on their feedback. They felt that the hospital was safe. They learnt a lot about hospitals, worked based on the project more so than the didactic lectures and the ad hoc shadowing of ward firms. And many of them felt more confident about becoming a doctor. And as a result of this project, as I say, the medical school supported medical students attending night shifts. And that is still sustained to this day. Next slide, please. So overall, our work highlighted the issues we suspected. So out of hours, there was an issue about the unreliability of handover, the importance of clinical leadership. So if you got the wrong medical reg, the wrong ITU reg, or the wrong surgical reg, and I use a wrong in terms of a leadership model rather than a right or wrong kind of concept, actually you get very dysfunctional teams. You get a lot of routine work being done out of hours. Support services are imperative, and even this is going back some time, but now with paperless documentation, it's really vital that the hospital at night team have easy access to IT that works. The Locum and Manpower issue is a problem, and that disrupts a lot of the structure and the culture, and Sarah will talk about that shortly. And we found that despite our best efforts, actually, because of clinical priorities possibly being not best aligned between the wards and the ED, there was a late detection and response to deterioration, particularly from the wards. So really, the project demonstrated quite nicely the value of the Hospital at Night programme and the value of the principles and founding philosophy from the Hospital at Night project, which was that you need a single team that's based on multiple competencies rather than grades or silos. It requires clear, consistent leadership and appropriate prioritisation. Next slide, please. And before I finish, I just wanted to include a slide on handover, because we looked at this as a side project with the Hospital at Night project, and it's something that will link with Sarah's talk, which is coming next. I urge you to also reflect on this in your own organisations, because when we assessed and analysed it, what we found was that 65% of patients arriving on the wards from ED were arriving out of hours. And that was quite an eye-opener to most of us. And these are often the most vulnerable patients. These will be the frailer elder patients who we know will wait longer in ED, maybe patients with dementia. For my own ward, we were cohorting patients who were actively withdrawing from alcohol. So actually we were getting a lot of clinical incidents related to withdrawal overnight because of the length of time it took to transfer patients from ED to the gastro ward, and they weren't getting benzodiazepines at the time. We know that junior doctor shift patterns are more challenging than ever, with 0 days and the like following on calls. But actually what we found with this project is if Wednesday is the least busy day of the week, then perhaps scheduling 0 days for a Wednesday would make more sense than 0 days on a Monday or a Friday. We also know that since this project was done, handover meetings are now a formal requirement of training. And Natalie and her colleagues at the next clinical learning event are going to be looking specifically about this. When it comes to handover, there's some really good innovative things that are coming along, including simulation training. But Sarah, I'm sure, will talk about the importance of senior leadership and the importance of using a structured approach for handover for all staff. And just to highlight the importance of appropriate facilities, so handover shouldn't take place in a cupboard or somewhere ad hoc. It needs to be somewhere that's properly resourced, including IT and areas for open discussion. So that's a summary of some of the work I've done previously on Hospital at Night. I'd like to thank my colleague Carlo Prina, who can't make it today. Carlo's a consultant, geriatrician and acute physician at Homerton, and we were partners in crime in a lot of the Hospital at Night work in East London. But if you've got any questions, please put them in the chat box, and I look forward to not only hearing Sarah's presentation, but to the discussion afterwards. Thank you very much.
Fantastic. Excuse me. Thank you very much, Andy. Great presentation. And I've already got lots and lots of questions to ask you later on in our Q&A. So I'm sure everybody else on the call is very similar. So as Wendy's just put in the chat box, any questions people have, put them in the chat box. And after our next expert speaker, we'll put them to our expert panel and our speakers. So our next speaker, we're delighted to have Sarah Stanley as our next key speaker. Sarah is a Divisional Director of Medicine and Urgent Care at Barnet Hospital. Sarah is also a consultant nurse for acute care and resuscitation and leads a team of clinical nurse specialists across the on-site teams at the Royal Free and Barnet Hospital. Also, Sarah is a qualified improvement advisor, and I'm really excited because I've had a sneak peek at your presentation, Sarah, to look at how you've used quality improvement methodology to sustain change in your out-of-hours care and your resuscitation team. So over to you, Sarah. Thank you.
Thank you so much, and thank you for the invite. It's very, very kind of you. Actually, when I was putting the presentation together, it was lovely that this team has now been going for 20 years, and I have been there for the whole time. It's probably time for me to move on, but in different forms. And I think that is important when you're trying to think about having a team stability, but also being able to innovate and move on. So next slide, please, Crystal. This is a very old slide, but I thought it was useful and I've just added to it. So this goes back to 2001. And I don't know if you remember, there was a seminal paper about you should be able to provide critical care without walls. And so we started initially with just follow-up from intensive care. And we've always been quite data driven and also trying to get publications in terms of nurse consultancy, and we showed that the team we had to follow up patients from intensive care could reduce readmission rates from 12% down to 6%, and we managed to get a publication in the BMJ in 2003. Now that only covered a small aspect, follow up from intensive care. The next bit is how could you stop somebody from going to intensive care if they didn't need to, if it was from a deterioration perspective. And also there were other elements such as tracheostomy care, non-invasive ventilation that occurred on the ward. So for the next sort of 7 years, I think we very much focused on reducing adverse incidents or reducing harm by trying to do lots of different things. We put the critical care outreach team, we joined with the resuscitation team to give us 24-hour cover, but both the skills of ALS instructors, paediatric instructors, as well as critical care staff. And the other aspect was around the right types of people to do these roles. So you could be an absolute expert, but have the wrong personality for attending emergencies, or, so I often employed for the types of personalities, and the other skills were easily taught. So it was something about getting the right people to do these roles. We took part in a number of other studies with intensive care medicine. We did a sub-study 7 for how much harm or how long people waited before going into intensive care. And I'm embarrassed to say we started a pathway called organ dysfunction and hypoperfusion, but it was actually a sepsis pathway, but we sort of were snobby intensive care people and actually then realised that wasn't the way to go at all. But I think for the first 7 years, it was very much about harm reduction. And then if we go to the next slide, I think we can see that we then really started to focus on understanding what was going to change behaviour in people who are busy, who are doing other roles, who are having to work in multiple teams. What is it you can design really more for human factors and actual digital innovations to push and pull information to the right people, so that if most clinicians, if they have the right information at the right time, they will make really good decisions, and thinking about how you might do that. So I became a nurse consultant in 2010. I then had 2 8A, it's a relatively senior nursing roles on each site. We did a lot of QI work on sepsis, which we'll talk about how we got there, but essentially we used proper, true QI methodology to get the sepsis 6 up and running in one area, which I have to say took us nearly 2 years to get it right. And then we spread to the rest of the hospital, which was very much against what the hospital wanted us to do, which was just to scale and spread very quickly. We then introduced a human factors study day, which we still run, and we also run the simulation centre, as some of the part nurses do simulation as well. And then controversially, we went into a partnership with a company called DeepMind, who were bought out by Google Health. We worked with them for 2 years on an app, which is still going now, but we're actually starting to merge that into a slightly different way of results viewing. But it was particularly for acute kidney injury, and it basically sent alerts to the part team if somebody's creatinine or if they were in an AKI 2 or 3, and we would respond to those calls, and we got a couple of publications out of that. The controversial bit is that we got into a lot of trouble with the ICO about data, people's data being used in different ways. Having said that, now NHSX are now picking up that mantle and are in a 10-year partnership with Google Health for the very same application and some artificial intelligence information moving forward. Obviously, News 2 came about. I'm sure everyone has been involved in that, certainly in the community and in acute settings. We also have EPR, Cerner here, other places might have Epic, and so we now have digital vital signs recording, all of which are great at telling you something's wrong, but the second bit is who does the right things about it. And then obviously for the last 18 months, 2 years, we've all been very caught up, as I'm sure we all have, in managing therapies such as CPAP and high flow nasal oxygen within ward-based settings, which perhaps some areas didn't do before. And we've been doing a lot of RSV teaching in PEDS in case their intensive cares are overwhelmed. But really what I wanted to focus on is kind of our themes, I guess, that have come out in 20 years, really focusing on more human factors and digital support rather than just ticking a vital sign and telling me that a new score is 10, for example. So next slide, please. So this is the team now. Out of interest, it is 24/7, which is key. At the Royal Free, we get 250 referrals a month, and they are the same number at night as they are in the daytime. And we have 2 band 7s on at night time, and we have 2 band 7s on in the day. And we have been extremely key in supporting the need for this care at night. And they do have a hospital at night team on the Royal Free site, not so much on the Barnet site, but they are key members of that team. Every single person does 75% clinical and 25% teaching resuscitation. And the 3 functions of the team, as most of these teams are, is follow up for intensive care, patient at risk activity, deteriorating patient, and they attend all 222 emergency calls for adults, peds, neonates, maternity, trauma, whatever. So they come with a range of skills that are all interchangeable and usable, certainly in different settings. The 3 sort of educational streams I would say we've developed over the last 20 years are really about simulation and human factors, which Andrew alluded to a lot, and how actually now I really believe you can use simulation for actually discovering the solution to the problem, not just learning when something hasn't gone perhaps well. And also in SI action plans, we've been using them in terms of the solution to how this might be done better the next time. Resuscitation, deteriorating patient, and including tracheostomy care. We have a lot of tracheostomy emergencies. There are UK wide, and you're trying to think about again how you can manage those sorts of airway emergencies. And the luck of having 24/7 CNS band 7s is that you have bedside teaching available 24 hours a day, 7 days a week. And the majority of our F1 feedback is around saving. They feel we are there as a friend and saving their life in a nighttime shift when they can't find anyone else necessarily to help and support them. And there's often basic minor things, information. It's not necessarily they don't know what to do. It's just working out how to do something or who to call or how to manage something at nighttime. I would say audit, research and improvement are all important, but I do feel now they are embedded within the team. And that I think is another key aspect in terms of how you might move forward with a service. So for the next slide, it just shows the themes. I think for me, when I was writing this, I think we all in the team see everyone as humans more, whether you are a patient, a family member or staff. Whereas years ago, you might have conversations around, oh, that doctor's been rude, or that nurse doesn't know what she's doing, and actually approaching people in different ways, which is something we all can do as individuals, but also sort of learning together and in teams. I think there's a huge element which Andrew brought up about clinical competence. Everyone in the team goes through some quite rigorous competencies. A lot of them are independent prescribers, all of them are ALS instructors, not only providers. And also we have critical care and acute care competencies. So in all honesty, it might take somebody 2 or 3 years to become a really competent band 7 CNS to be able to provide the right level of support that is required 24 hours a day. There are huge benefits of being clinical and teaching in that actually I could be seeing us all on a teaching course together and the next day I'm doing it clinically just the same as everybody else. But there's negatives in that often if there's short staffing or issues that need doing, the teaching often gets cancelled potentially. So that's the sort of negative. I just mentioned before, I really do think this is about us as human beings, how we feel each day, how we have good days and bad days, irrelevant of whether you're a healthcare practitioner, and also us thinking a lot more in systems and understanding that, something should function with or without us, and how do we make that happen continuously. There's so much room for innovation and so much room for information pushing and pulling, which I can show you some slides on shortly. And learning from improvement. Every single thing that I have done has been on a very small scale to begin with. Really test its value. Is it just change for change's sake, or did that individual change actually make something better and it didn't have a negative impact on something else? And I cannot underestimate the use of digital in the future. I think remote monitoring, push notifications to individual teams or specialist people, whether that's in a health setting, in a primary care, somewhere else, may absolutely be the way to go forward. For COVID recently, when we were doing a trial at the Free, and we were giving them doses of COVID, actively giving them doses of COVID. We put remote monitoring in terms of wristwatches on them the whole time, so we didn't have to continuously go in and out of the room. And again, I think there's an awful lot of mileage in thinking about that short and longer term. Next slide, please. I'm just embarrassed by this chart now. I have to say, I thought this was absolutely fantastic when we started, and it's complicated and difficult and on paper, and it just shows you how far we all come over time in trying to get people to, one, document that the observations are not right, but two, in letting them work out who they're supposed to call, how it's supposed to work. So it's really an example of, you think you've got it solved by just saying to somebody, fill in a form, but the reality is it doesn't necessarily work like that, and we need to think about different ways of getting people to understand somebody is sick and how you get some help reliably. So next slide, please. So we had all of these things in place, and all of us, I'm sure, have had cases like this where a young person or a person has died. We had a patient safety program running for 3 years, and this was a patient with lupus who sat in an outpatient clinic with a blood sugar of 1 and was moved to a ward, and somebody asked her if she was diabetic, and she said she wasn't, and they tried to give her a drink when she was semi-conscious. They put her in bed 28 in the ward, and her sepsis was missed at every single stage. It was her mother who came to visit her who ran down the corridor shouting that something's not right. And when we look, there are a lot of SIs potentially related to failure to escalate sepsis type patients, as I'm sure lots of you have experience in. And we had an SI, big external SI, and I couldn't bear to just do another set of guidelines and write another form. That wasn't the way to go. It was going to be much better to rethink why it was difficult for us to identify when patients are unwell. So next slide, please. So we did do news charts, and we designed a sepsis pro forma, but the big trick here was that I didn't design it. The people in this area designed it. So this is an obstetric sepsis protocol, but the A&E staff designed their own, and they also designed how they were going to deliver those 6 things. So it was entirely up to them. Did they have it in grab bags? Did they have it in trolleys? Did they want it by each bedside? All of those things were up to them. And this is a version, this says draft 2, but we had 58 versions of this protocol before it actually started to work, that you and I, without any training, could turn up and we could fill this in. Obviously, now we've moved to a more digital setting. This is digitized somewhat. Next slide, please. So we used, this is quite an old-fashioned way of recording it. Now we have a lot more sophisticated software, and I'm sure lots of other people may do, or they may have their own IT solutions to having sort of SPC control charts. But essentially, it was just an example of how we monitored continuous data, allowing individual sites to design what they wanted to. So they launched it. Did they want guidance? Did they want staff feedback? Some staff loved a safety cross on the back of their team door. Other individuals like patient feedback about what happened to the patient that they saw. We had ED champions collect data differently. They tested grab bags. They tested pathways. When the F2 doctors changed over, they led some of the new suggestions and changes. And eventually, we got to 90% compliance to all 6 elements, not one element, all 6 elements in all of the trust that we had, which is Barnet and the Royal Free. We didn't do Chase Farm. They had an urgent treatment centre essentially. And for here and now, we have not since then had an SI related to sepsis. We've had deteriorating patient related incidences, but not sepsis. This has now been digitised, but I think this principle for me was about learning how you get a whole scale hospital. This was done with 1 band 7, spending half a day in different clinical areas over a period of time, and allowing them to design what they wanted to do. Now, lots of other people may have examples of this, and I'm sure we could be more sophisticated and faster, but we did stick to the rules of not moving until our PDSA cycles were actually yielding results. Next slide, please. So then the other sort of aspect I think about improvement, which I have to say, working with Google Health, they work in exactly the same iterative process design. They absolutely allow patients and staff to design. It's not a fixed off-the-shelf module IT package that you have to do. You are allowed to play around and say, I don't want the GP details. I want the blood test results first. Then I would like the OBS. Then I would like it in this form, because that's how my intuitive workflow fits. And they had a pathway for AKI, which they felt they could cut out a huge number of elements. If you look at the top row, the slides might be quite small, but the top row had lots more steps in it, and we reduced it to a lesser row. We then worked out how we could real time and send mobile results to us, and how it was just us that could test it, and then check the response times and whether we could do something about it. Now, for me, the response times are that sort of biological or chemical markers are often a lot quicker than your blood pressure dropping or your heart rate increasing, or you may be on medication to control that. And so it actually, what it did is gave us more time to visit the patient early to then decide what the right treatment pathway was for these patients. An awful lot of these AKI3 patients were dying, and actually it gave you more time to make appropriate plans rather than being called to them when they're in absolute extremis. And so from my perspective, whilst it might not have saved large numbers of patients, what it did was highlight treatment pathways that perhaps were better managed. It did save an awful lot of maternity patients, which is very interesting. They were often in labour, in the throes of labour, or having a C-section, and their creatinine rise was not picked up by the team who were caring for those patients at the time. So about 5 ladies a month we get sent or who are in AKI 2 and 3, either from UTIs and sepsis or fluid loss. And that, I think, is a real a win in terms of pushing that kind of information. Mary is one of the people in the team, and the other benefit is you can actually show patients their creatinine rise and fall. They can actually potentially have the app themselves, and they can be able to see and monitor for long-term chronic conditions, perhaps what their bloods are doing, and learn themselves when they might need to increase their fluid intake, or in fact get themselves some antibiotics or stop some of their medication. Next slide, please. The other thing I know that Handover for me is that we go through rounds and rounds of different tests in the team. I think I do drive them nuts, but this is the latest one. So at the beginning of every handover, 1, they are all sitting down. 2, they have to read this out. Now, it might seem silly, a bit like a checklist on a plane, but what it does is it stops everyone from talking. It focuses the mind. And it also allocates 1 about interruptions, but 2, who is going to go to the next arrest, so that handover doesn't get interrupted. It's stuck on every single person's computer. We change it regularly, but that's exactly what it does. And then the handover works by the first 10 minutes are handing over patients using SBAR. The next 10 to 15 minutes in reality are everyone having a bit of downtime debriefing. What they tend to do is moan about something that happened, talk about a difficult case, or just do impressions or laugh or cry or whatever it is they need to do, which I think is a really good close for the end of the shift. And then the day shift kind of starts. It never lasts more than 30 minutes. We time it every time. And I do think it's something that we don't learn about. We talk about handover, but what are you going to do in that handover? And are you going to be able to compartmentalize it? Everybody needs to tell you what a bad night they've had, and that's absolutely the right thing to do. I think it makes you sleep better if you do that. But what I want to know is, as a day person, who are you worried about, and who do you want me to go and see, and in what order? I don't care what antibiotics they're on. I don't care how much fluids they've had overnight. Lots of people tell lots of detail that they think is important. So the other aspect we focus on an awful lot is really tell me who's bothering you. We know each other all well enough. Why are they bothering you, and what would you think you want me to go and focus on now? And often the first 2 or 3 patients, it's really obvious who you need to go and see and in what order. Next slide, please. The other bit for me, I think we're really starting to really motor with is understanding patient and staff simulation. So after every emergency call, adult emergency, peds emergency, we don't call them cardiac arrest calls so much, but just emergencies. All of us are trained in AAR and debriefs, and actually just checking in with the team. It doesn't matter who leads it. It can be the member of the part team, can be anyone else, is just using some debriefing and some simulation. And the more and more we do, we realise it's actually more of a support tool. It actually helps with thinking through future, and actually it's much better to focus on doing this all the time when things are going right for learning, because that's what people take away from it, rather than focusing on when something has gone wrong. So we now really believe that almost we're doing these 2 or 3 of these a day, and people are actually starting to expect them to happen rather than it be a shock. The bit is everyone's busy, people have got other patients to see, not everyone can stay, but on the whole, I would say nowadays it's much more common for after every emergency, people will stay for 5 minutes just to be able to talk to each other. Again, I don't know if that's other people's experiences. Next slide, please. And we have in our team, we have a couple of people who are getting older, and doing clinical work all the time is harder. And so they've moved into running the simulation centre, but they still do 50% clinical. And they have been focusing on this stop for 5 minutes, which is the Edinburgh Emergency Medicine. I think somebody's mentioned that in the chat as well. So just summarise the case, things that went well, opportunities to improve, and points and actions and responsibilities. And again, whilst it might be difficult to attend and do, I think more and more people are familiar with it. What I think is great is a band 5 and an F2 and anyone else you could ask to be involved. And just even if they weren't involved in the case, it's just an opportunity to explain what we think happened. And even if the patient's died, which is often the case, it's more about saying that went really well, although the outcome for the patient may not. The point is that all the right things happened, and that's the learning that you want to take away from it. The other bit for me, I think there's one thing we can all take home as a message, is sometimes just asking everybody if they're all right. If somebody's having a bad day, just saying, are you okay? And often for junior people to ask senior people might be difficult, but you'll probably be surprised what a lovely reply you'll get if you potentially do that. So I think it is a lot more about us focusing on humans and learning, rather than, oh, I forgot to do something, or she didn't do this, or he wasn't nice. So I think changing the emphasis of that is the way to go. So I think that's my final slide. I just think I've been really lucky to work in this position and been really well supported. And I now have the fortunate position of being a sort of a divisional director, so I can hopefully carry on these kind of traits in larger scales with other teams, be they specialty teams or hospital at night teams. So thank you very much for listening.
Well, thank you so much, Sarah, and thank you to Andrew. 2 fantastic presentations, both different but following on from each other as well. And really interesting, Sarah, how you've added value to the handover, something as doctors that we're always trained to say is a dangerous part for patients, but actually added value to it, both from the moaning section of the debriefing, but also getting very concisely through that initial statement what people actually need to understand. So previous attendees of these calls know that the last 15-20 minutes of these calls is where you guys have the chance to ask questions, but also we have the fantastic resource of our clinical reference group on the call. And we've added to that today with a couple of experts in hospital out of hours as well to ask questions to. So please, I've seen a few already come up in the chat box, so please ask some questions to our team. But I'll use Chair's prerogative first just to ask a question myself, if that's okay. And when I come to members of the clinical reference group, if you mind just introducing yourself, and then that's so everybody knows who you are. Lynn, if you don't mind, I always come to you first. I think it's really powerful having the patient voice after hearing from our clinical staff. You put a really nice comment in the chat box. Whenever I talk to lay people about hospital at night and stuff, they're always surprised by how poorly staffed it is, or how sometimes old-fashioned people think that our hospital out of hours work is. But we've heard 2 fantastic examples today of more modern practice. What's your reflections of what Sarah and Andrew have led?
Thanks very much, Dan. I don't mind you coming to me first, really. Yes, as I put there, I mean, so much that I've heard today was new to me, and so much of what I heard was, as I said there, I mean, really, I think you'd be hard pressed to get to find patients who said, oh, I don't like the sound of that. Very, very reassuring. And I mean, from the very explicit statement that Sarah made, which I've written down here, about seeing patients and family and staff as humans. And I really do think that it's important that we need not only the guidelines and the protocols, important as they really are important, but it isn't just about following what's on a piece of paper. It is that human side as well. And I do very much believe that where staff are valued and cared for by one another and by the people in charge, I think that has a definite knock-on effect on patient care and patient safety. I'm very much an advocate for staff well-being being important in order for patients to be safe. I think patients, it's always difficult because I'm only one person. Obviously, I have been a patient. So I'm always sort of conscious that I'm not speaking on behalf of everybody, but I think from being a member of the Patient Carer Network and speaking to people over the years that I've been involved, I think it's true to say that patients do, you kind of suss out when things are not going as they should go, where there isn't effective team working, where the multi-professional team isn't working as a cohesive team, where professionalism, dare I say it, is perhaps getting in the way. I think it becomes apparent to patients. And I think also, times of a handover, for instance, when that isn't working smoothly, it becomes apparent to patients and to their families. So I think all that I've heard this afternoon from Andrew and Sarah, as I started off by saying, is hugely reassuring that care is being taken, and I'm sure that there are lots of people on the call who are already doing these fantastic things as well, and it will definitely, I'm sure, show in how patients regard their time being in hospital. So thanks very much.
Thank you so much, Lynn. I wonder if we could come to Cheryl Fagan, who's one of the hospital at night nurses at Sherwood Forest Hospitals and an ex-colleague of mine. Good afternoon, Cheryl.
Hi.
A question I thought that was really powerful that Wendy put in the chat box. I thought you'd be really able to ask, and it's Andy also mentioned it in the chat box about shared competencies. And so how, from a hospital at night practitioner, you've supported hundreds, thousands of junior doctors of different specialties. How do we support different specialties, gastroenterology, stroke, cardiology, and how, from a nurse's or a practitioner's point of view, do you develop those shared competencies?
It's like being a role model, that expert in your field. Our team is made up of different nurses from different backgrounds, and how that we pull together to work alongside each other. And then we use Nerve Centre, which is a really great way of being able to communicate with your team, but also to keep an eye and support them remotely from that point of view. But it's also knowing your team, and knowing actually you don't need to know everything as a coordinator in a way, but knowing where to pull in from. So knowing your specialist areas and communicating with them, knowing where to send the doctors when it gets busy and things along those lines.
Thank you, Cheryl. My voice may last another 5 minutes. I'll keep pushing on. We've heard from doctors and we've heard from nurses and specialist nurses. I wonder if we could hear from one of our allied health professional colleagues. And Katerina Nolan, I don't know if you're free to speak at all. What's your reflection on hospital out of hours from an allied health professional point of view in terms of moving towards 7-day working, and where do you see your kind of place at 4 o'clock in the morning?
Yeah, so that was my initial thought when we started today. I was like, where do we quite fit into this? Hopefully, there is a place, but I think it's going to be more the later on end of, like a long day, early morning. But NHS is an evolving process. You might find a therapist at 3 a.m. in the morning outside of respiratory on-call work. There might be scope for lots of things. But I think some of the key things that I took up from today was not to just rest on your laurels as such. There was lots of good work done, but it was repeatedly then PDSA'd for improvements. And I think what each cycle showed was that even if it was small, there was an element of improvement that could be gained from that. And there were some really subtle things that I think actually carry, for me, a real weight of impact, and also something that Lynn had said. It's very easy to identify a dysfunctional MDT or board round or ward round. It's not so easy to put your finger on the really efficient ones. What is it that they're doing that's really efficient? Sometimes that's kind of harder to capture. But I think it was Sarah that said the thing around, it was a script that people had to read, and they identified people within the team at a level of responsibility that were going to respond to emergency calls or something else. And I think there's transferable elements within that, so that actually the ward round or the board round isn't disrupted completely, that it can carry on simultaneously dealing with other issues that are arising, but that everyone knows their role and responsibility within that. So there's something there for me around very clear communication, get the key messages out quickly and early. And I think there is, you know, when you have a kind of a script bit, and it can feel a little bit in a very efficient team, a bit sort of, oh, it's a bit mundane, I'm having to do this. But actually, it's because you're efficient that you almost feel like, I don't need to say it, but I'm going through the motions. I think you see probably the bigger impact in less efficient teams initially. But there's a pause for thought. So when you have a changeover of shift and people come in, there's the excitement of everyone meeting up, maybe because they haven't seen each other in a few days, and some have been on long days, short days, annual leave, all sorts. There's the element of those wanting to hand over information and just get home because it's been a long day. And it's a moment in time to pause and actually everyone realise, okay, the formal bit is starting now. We've all got our role and responsibility, so let's step into those shoes now and not be the kind of all embracing, I haven't seen you in 4 days, Mary, how's it going approach. So I think there's that. I've even just in the day shift bit, I was thinking there's transferable bits here for just about everything. And I don't think they're to the exclusion of AHPs either. So I think it was almost probably underestimated, but for me, there were big things that came out, and obviously recording all of those PDSA cycles, but that there was change at every point. So not to give up, really.
Well, thank you, Katharina. Thank you. Going back to the Mentimeter in the final free text questions, there was lots of questions about lack of support or lack of funding for hospital at night teams or deteriorating patient teams. Andy Aldridge is on the call, who's one of our clinical, one of our improvement managers I know has supported the development hospital at night teams. I don't know if, Andy, you have any hints and tips for people on the call who might be struggling to develop these services? Or I might be asking Andy and he might have just jumped off the call, unfortunately. So I wonder if I could come to John to bring the meeting together to an end, to summarise a little bit about what we've talked about, but to bring it back to the modern ward round document itself. And one thing we really, Andy Rochford talks about it, we haven't really highlighted on it, is the importance of legacy tasks, isn't it? And also prioritisation of work, because as Andy's audit showed, we understandably prioritise new admissions because we don't know much about them, but potentially to the detriment of some of the ward patients.
Yeah, sure. I mean, firstly, great to hear those presentations and very thought-provoking. I think a lot of places have worked very hard and started with small critical care outreach teams that have then developed in terms of their scope and their skills to then be 24/7 and supporting wards and other staff. And there are some key factors I think that are around success. One is that team being seen as part of the extended ward team, so that if there are reviews happening on the ward, that is done in conjunction with the ward team. And clearly out of hours, the ward team can feel more vulnerable and greatly supported. How that then feeds into, if it is out of hours, into that early morning handover, board round prioritisation has to be key to the ongoing work of prioritisation of patients and assessment. And similarly, late afternoon into the evening, particularly on Fridays, how we get that check-in, how we're doing, what hasn't been done in the day, what can wait till tomorrow, and what absolutely needs to be done tonight by the whole multi-professional team is important, because many legacy tasks we find when we examine them actually are not needed until the next day. They're not urgent. They're just things that haven't got done that day. So working as a team to agree that in a multi-professional way can really help with the prioritization overnight. But I think handover is such an important way for the way hospitals, teams work together for patients. Watch this space. There will be more stuff coming out in the future. I'm sure both from ECIST and RCP, we've learned a lot on handovers over the years. There's some great examples around, but there are a lot of places, unfortunately, that need to improve practice there as well.
Well, I will just echo what John just said about the fantastic speakers and the fantastic conversation we've had in the chat box. I think we could have talked about this for at least another 30 minutes, if not an hour. And I'm sorry that we haven't come to all members of our clinical reference group today. We're just running out of time. For one, I would have loved to hear about Dr. Gordon Caldwell's work about in situ sim. I think it's a real opportunity we don't take enough up about in situ simulation on our wards. So just to summarise again, we've heard a fantastic presentation from Dr. Andrew Rochford today and Sarah Stanley. Thank you so much for your time today, guys. Thank you so much to our clinical reference group, especially Lynn and John, who are fantastic supporters of this collaborative. Just a bit of an advertisement. Our next learning event is on the 20th of October on Wednesday. This is talking about the multidisciplinary team working and how we maximise learning as a team in our ward round collaboratives. And another little plug, we only learned how to improve these sessions if we get feedback from our attendees. So please fill in our learning and feedback survey, and we can learn how to tailor and edit these into the future to make them as useful as possible. And if you love the sound of my croaky voice, you can watch these videos again on our YouTube call. So again, thank you very much all, and have a good rest of your day.
Thank you.
Thank you. Bye-bye.
Thank you.
Daniel, the in situ sim, I did as a really low tech thing. Do you remember the alert program, which I think came from Portsmouth? And they just used to say to you, you're very breathless, sit on the chair and be very breathless. So we were doing this in the 3 months up to COVID, and I would inevitably be the patient. And the first scenario was that I'd been brought in convulsing and I was diabetic and I was hypoglycemic. And then we did it, I think 8 o'clock on a Friday morning, 8 to 8:30, 10 minutes of the most of the simulation, 10 minutes debrief, something like that. And the very first one, we discovered that our instructions of how much intravenous glucose to give was different depending which box you picked up. Now, if you had it in the simulation suite, you'd never have picked that up. And things like they were running off to get the glucagon in from the fridge because they all believed it was in the fridge, but it's actually in the hypo box at room temperature. So it wasn't just the rehearsal of the event, but it was also the testing out the actual reality of the situation. And then the other bit I got as the patient was you get this immense feeling of what it's like to be the patient. And each time I was the patient, I sometimes had horrible things like tension pneumothorax from a road traffic accident. Our nursing staff was so reassuring and so calm. And then all the stuff, the usual stuff comes out. Who's in charge? When a new person who's the boss comes in, are they properly briefed and things? So, and I reckoned I'd never be able to handle a simulation suite and all the IT kit and all this crap. And just doing it at that very, very low level. One of our radiology technicians, staff who actually books the people in for their appointments, she's an amateur actor, and she did a psychotic patient and trying to manage a psychotic patient and things. So I think there's a lot of mileage because you're testing your ability to deal with the situation in the real environment. And if you've got somebody there who's the patient, you get that extra feedback, and you're testing the systems you've got in place as well. And it takes no time at all to set up. You know, if you take the top 20 medical emergencies, you've got 20 weeks of simulation just for this, 5 minutes work of writing a script and telling somebody what to do.
Yeah, no, it's really powerful, isn't it, in situ? So like we used to use it to induct junior docs into non-invasive ventilation, and the value that the band 6 nurses led to those in situ sim compared to sleep consultants. It's amazing. And it's weird that we do in situ sim as doctors very much in procedure-based specialists, don't we? Anesthetics and things, but we don't often think about it from a more medical ward base.
So unfortunately, when COVID came along, then all the restrictions sort of went, and I keep thinking we should get back to doing it, because it was very good learning all round. And sometimes, you know, the medical students will be given the job of leading the team, and then we're teaching them that you've got to ask for help. You know, stop soldiering on trying to solve this problem by yourself. Phone for the consultant anaesthetist now.
Well, thanks, Gordon. I'm sorry.